All right, today we're tackling a topic that is without a doubt a true medical emergency: the initial management of suspected bacterial meningitis. This isn't just a diagnosis. It's a race against the clock where every single decision we make has huge implications. A structured, super rapid response is what makes all the difference, and that's exactly what we're going to break down. Let's dive in.
And just before we get started, it's really important to note that all of the clinical guidance we're about to cover is based on the work of Dr. Mohammed Al-Naghi Mohammed. This ensures that the framework we're using is solid and grounded in established medical practice. This quote right here, it perfectly nails the central challenge. You see, with a lot of conditions, you get to investigate, get your definitive diagnosis, and then you treat. But with meningitis, you just can't do that. You have to do both at the same time. Why? Well, because a delay of even an hour in getting antibiotics on board can be catastrophic. So this idea, this principle of investigating and managing simultaneously, that's the foundation for everything we're about to talk about.
So where does our management pathway actually begin? Well, it starts before the patient even hits the hospital doors. The actions taken in those very first moments, often by paramedics or a GP, are absolutely pivotal.
This really lays out the pre-hospital priorities perfectly. Step 1 is the big one. It's totally non-negotiable. Get the patient to a hospital, urgently. That is the single most important thing you can do. Now, step 2, giving IM benzylpenicillin, that's a consideration, not a must-do. It only comes into play if you're specifically suspecting meningococcal disease, the classic non-blanching rash. And here's the crucial part, it can't delay that transfer one bit. The priority is always getting the patient to definitive care.
Okay, so the patient has arrived. Now we shift gears. We move into a systematic, universal protocol for assessing any critically ill person. And that, of course, brings us to the ABCDE approach. It's the framework that brings calm and structure to what can be a really chaotic situation. We always start with the ABCDs. It's the bedrock of emergency medicine for a reason, right? It forces us to find and fix the most life-threatening problems first, in order. It stops us from getting distracted by something else before we've secured the basics.
First up, A for airway. Is it open? Is it safe? We have to check. In meningitis, a patient's GCS can drop, and when that happens, they can lose their protective airway reflexes, like coughing or gagging, so this becomes a really critical check. We're listening for any gurgling, any stridor, and we're ready to jump in with simple maneuvers or even advanced airway management if we need to. Nothing else matters if you don't have a patent airway.
Next, we're on to B for breathing. How are they breathing? We're checking the rate, their SATs. Are they using extra muscles to breathe? This is so important because raised intracranial pressure, a major complication of meningitis, can directly mess with the respiratory centers in the brainstem. You might see weird breathing patterns or even respiratory depression. So watching their breathing is one of our best windows into their neurological status.
Then it's C, circulation. Bacterial meningitis can spiral into sepsis and septic shock incredibly fast, so we're hunting for signs of circulatory collapse, tachycardia, hypotension, a slow capillary refill. And this is the point where we get that IV access. That line is our lifeline. It's our gateway for fluids to fight shock, and most importantly, for the antibiotics that can literally turn the tide of this disease.
And that brings us to D for disability. This is our quick, focused neuro exam. We're getting a GCS to see their level of consciousness. We're looking for any focal signs, maybe a one-sided weakness. That could hint at a complication like a stroke. Are they seizing? And we're also checking for papilledema, swelling of the optic disc. But here's a key clinical pearl. Papilledema can take hours, even days to show up. So just because you don't see it, it does not mean you can rule out dangerously high intracranial pressure.
So, we've done our initial ABCDE survey. What's next? Well, now we have to figure out the immediate risk. Are there signs here that tell us this patient is on the verge of crashing and needs senior help? Like, right now? And the guidance on this could not be clearer. If you see any of these warning signs, a senior review isn't just a suggestion, it's mandatory. This is a critical safety net. It's built into the system to make sure that the sickest patients get the most experienced eyes on them as fast as possible.
So let's look at some of these specific red flags. A rapidly progressing rash, that screams meningococcal septicemia. Poor peripheral perfusion is a huge sign of developing septic shock. And the respiratory rate, well, it's such a sensitive marker. If it's below 8, you're worried about respiratory arrest. If it's above 30, that signals massive physiological stress. Any one of these means you need to escalate, immediately.
So, if we tie this all together, what's the one crucial takeaway? It's that in suspected bacterial meningitis, everything, and I mean everything, is about the clock. From the pre-hospital phase, through the primary survey, to spotting these warning signs, every single step is designed to shave off minutes and get life-saving treatment started. Early recognition and rapid action. That's what saves lives and brains.
So let's end with a question, just to really let that key point sink in. In this kind of high-stakes scenario, when every single second counts, what is the one action you absolutely cannot afford to put off? Thinking about that really hammers home the core message. In bacterial meningitis, urgency isn't just a part of the treatment, urgency is the treatment.